Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to today's webinar titled Animal Welfare in Surgery, Then and Now, featuring Dr. René Remie, Director and Professor Emeritus at René Remie Surgical Skills Center. Today, he will present the foundational principles of surgery that have evolved into good surgical practice. I wanted to take this moment to thank our partners at the American Physiological Society and the sponsor for this event, 80 Instruments, for making it all possible. I am very pleased to welcome Dr. René Remie. Hi, René. Thank you so much for being here with us.
Hi,
And
Sarah.
please take it away whenever you're ready.
Okay, thank you. Now, first of all, I want to thank the audience for attending this meeting or this webinar. 80 Instruments, of course, for sponsoring the American Physiological Society. And you, Sarah, for hosting this event. Good, let's start with animal welfare and surgery then and now. This is the agenda, and you will see that I hop from the past to the future to today. And talk about animals, about the surgeon, about how we did surgery a long time ago, how we were trained, and how we had no textbooks, in fact, or almost no textbooks to read and to develop our skills. A few words about the anesthetics that were used in the past, and of course, we will zoom in on what we use today. Several bad things changed when the laboratory animal science was born, and the 3 R's were very important after their introduction in 1959. I will talk a bit about Hallstatt, of course, and people who have attended my courses know that I'm a big fan of Hallstatt. I will talk about the change to freely moving animals, the germ theory, asepsis and antisepsis, surgical instruments because they are crucial in good surgery, a few words about catheters and sutures, perioperative care, patient monitoring, and I will finish the webinar with some words about radiotelemetry and the current situation there. Animals, and especially rats and mice, were taken into the lab a long time ago. And for the rats, we know that they were introduced around 1880 in the Wistar Institute of Anatomy and Biology. And they were domesticated. Helen King was doing that for that company, and they bred very nice animals. They were socialized, and they started to sell them, and they traveled around the planet. They had to change husbandry and nutrition and environmental control because these animals had a lot of endemic and natural pathogens, and they wanted to get rid of some of them. In 1946, it was Bengt Erik Gustafsson who was the first to breed germ-free rats, and that, in fact, was the start of the SPF way of breeding animals, so specified or specific pathogen-free animals. That was a very good step forward, but we still had problems with viruses. And I remember that between 1980 and 1996, we had several breakdowns at big breeders, Killam red virus, mouse hepatitis virus, respiratory virus, and we had no clue what these viruses were doing on our experimental results. So the only thing that we could do was kill all the animals, and the breeders had to start their breeding completely from scratch. So very expensive, and a lot of animals that died there. What we see is a constant decrease of types and amount of pathogens in our laboratory animals, and SPF and SOPF, so the specific and opportunistic pathogen-free animals, are the standard now. A few words about the surgeon. It's coming from the Greek, chirurgos. Chiros means hand, and ergon means to work. So we are manual workers, and that's true in the strict sense of the word. When we look back in time, surgery in 50 years ago was very often done by self-trained people without an assistant. People trained themselves and used a lot of living animals, had a lot of technical failures, high numbers were used. Disappointed learner syndrome was very often the case. Oh, I will never learn this, let's stop. Take it together in animal consuming autodidactism. This is what I used to say. Next to that, people were treating the tissue terribly. And we talk about meatball surgery here. So if you grasp the tissue 100 times, you kill so many cells that it looks like a meatball. Needless to say that this leads to unnecessary suffering and probably also unreliable results. In the past, lots of surgeries on one day, no survival. But when we realized that anesthetics, but also restraint had a huge impact on the physiology, we started to use freely moving animals. And that started around 1960. Popovic were the first to publish papers about permanent catheterization of the jugular vein in the rat and the ground squirrel. And at the same time, we started to increase our legislation in Europe, at least in the Netherlands, in 1972. But in Europe, it was the 86609 guideline that introduced the ethical committees, and more recently, the 201063 that wanted animal welfare bodies look at the refinement of animal experiments. Here you see an example of Asfar, who wanted to master training the kidney transplants in rats. And first of all, he practiced 168 hours under the microscope, and for that he used rats. And in fact, that is not very necessary. He could have done that differently. He accepted his technique only when the ischemia time was less than 20 minutes. And that brought the total of animals used to 238 rats. And that's a tremendous high number. At the moment, we still train people in kidney transplants, and we can save at least up to 90% of this animal number. Yeah, here you see the presenter in 1976 when I was young and beautiful. Now I'm neither young nor beautiful, so I have to do with it. I'm working here on a rat and isolating a uterus from a female rat that was studied by the students in vitro. So training is very important, but there are several pitfalls in training. I see that technicians and researchers in the past were badly trained. They were trained by a colleague, or they were self-trained. And when you were trained by a colleague or by an expert, the rule of see one, do one, teach one, that is not a very wise thing to do. So experts train a student, the student becomes the teacher, then teaches another student that will become the teacher, etc., etc. And the cartoon says enough. So at the end of the line, the message is completely changed, and nothing of the original is there anymore. Another thing that students do, and that's not their fault, but it's their teacher's fault, is take over the mistakes of your teacher, because you believe what your teacher tells you, and you try to copy that. But you also copy the mistakes. So we often see this with hand positions in people working under the microscope. It is very often difficult to change these bad habits. It can take a couple of days, and then, even then, when we have changed these bad habits, when there is a stressful event, the system goes on autopilot and people start making the same mistakes again. So once is enough or not? Is training once enough? I don't think so. First of all, there is quite a bit of information loss in time. If you do not do a certain surgery rather frequently, you lose your skills. And the half-lifetime of knowledge is approximately 180 days, at least for theoretical knowledge. For practical knowledge, can be a little bit different, because everybody knows how to ride a bicycle, at least in the Netherlands, and you don't forget to do that. But after 3 years, when we apply the rule of waiting 5 to 6 times the half-lifetime of a drug in pharmacokinetic research, that would mean that after 3 years, all your knowledge is gone. And this is very true for anatomical knowledge, by the way. So in the Netherlands, and probably also in other countries, nurses and other practitioners in the health sciences, they have to be trained when they haven't done a certain technique in a year, and they must be trained under the supervision of an experienced person, and then that person can sign off, and then it's all legally guaranteed. The 1063 guideline that I just mentioned also contains a sentence where they asked to be trained on a regular basis. So this is a good step forward. The anesthetics. Yeah, has been a lot of changes in anesthesia in the last 50 years. But going back to the beginning, Plato, and that was 375 years before Christ, already described pain as an emotion that dwells in the brain, and that was very good for that point in time. Descartes, the French scientist and philosopher, in 1664, claimed that pain came from the brain, and that was spot on, because pain is indeed a concept of the brain. Of course, he had no clues about nerves and stuff like that. So that was, in his opinion, a tube running from the leg that you can see here close to the fire to the pineal gland. And when the foot was too close, there was a bell ringing in the brain. That was the warning signal. So, in fact, not much has changed since then. Surgery also changed, and we will come back to that later after the introduction of anesthesia. That was 16th of October, 1846 in Massachusetts in the Ether Dome. Demonstration done by William Thomas Green Morton together with the surgeon that you can see on the Warren on the lower right panel. That was a good success. Not everybody accepted anesthetics, because the religious traditionalists objected that pain was God's way of cleansing the soul. But anyway, it was for the people who had to have surgery. It was a blessing, because otherwise you were in agony. 1 year later, in 1847, chloroform anesthesia was introduced. If you want to read more about that, there are beautiful books of Julie Fenster about Ether Day, and of Stephanie Snow, who is married to the grand nephew of John Snow, the original introducer of chloroform. Both ether and chloroform have been replaced in the last century. Halothane was introduced in the 50s, isoflurane in the early 80s, and sevoflurane, which will be probably the successor of isoflurane, was introduced in 92. Also, injectables were used in surgery. In horses, chloral hydrate was used. Pentobarbital was used in the early 1900s, and thiopental was developed, a short-acting barbiturate, in 1934. Later, ketamine, the dissociative anesthetic that we had no clue how it worked, but it worked, and today we know that's a glutamate receptor antagonist. Etomidate, metomidate, all drugs that give excellent sleep but do not kill pain. And fortunately, today it's much better than some 20, 30 years ago. But when I visit institutions or talk to people about the anesthetics that they use, in the past they were often very outdated, and there was a local folklore that was, this anesthetic is what we use in the lab. This is standard. But very often that was inadequate. Let's have a look at the anesthetics now. We know that it's not good to give one drug, and we like to think in the four-pillar model. The four pillars are the mental block, where an animal is sedated or under hypnosis, where it doesn't feel any pain because of a sensitive block, and a motoric block. Now, fortunately, many mental blockers have a motoric blocking side effect, so the muscle relaxation is okay. If not, then you can add some muscle relaxant. And of course, the fourth pillar, the autonomic block, mainly to inhibit the vagal activity. Injectable anesthetics today use this multimodal approach, for example, neuroleptic analgesic combination, so a neuroleptic drug combined with an analgesic drug So the analgesic is methadone and the neuroleptic drug droperidol, fentanyl, the analgesic, and fluanizone, the neuroleptic, combined with the muscle-relaxant midazolam. It was a very popular substance in the late 80s and early 90s. Unfortunately, fluanizone was taken off the market by Janssen Pharmaceutics, and we had some problems with getting Hypnome. But some people stepped in that gap, and it's still available. Today, sifentanil, one of the most potent opioids, in combination with midazolam, can be used in dogs and pigs. But in small rodents, we very often use the combination of ketamine with dexmedetomidine or xylazine, and in mice, we prefer to add a small amount of azithromycin. And then we have covered the majority of the 4 pillars, and we have very nice anesthesia. Inhalation anesthetics today, as I already said, isoflurane is the one that most people use, but we will switch to sevoflurane in the near future. It has a very low blood-to-gas coefficient, and that means that it has a very rapid onset of action, and that also means a very quick recovery for the animal. The books that we had, and especially the books that I had that I could study, the book published in 1942, The Rat in Laboratory Investigation, a beautiful book that was edited by John Griffiths and Edmund Ferris. Ferris was the executive director of the Wistar Institute of Anatomy and Biology, and that institute indeed had a vast knowledge on rats. Some funny things here. Below left, you see the applying of the ether mask, and the reason that they used the ether mask and held the animal with a glove with iron in it simply was that the method was wasteful of ether, and it was time consuming, and you had to use the mask anyway afterwards. So that was the reason not to put the animal in the ether jar. They also injected animals, and this is really a beautiful example of a rat that is wrapped in iron gauze, and then they do something that's very spooky, because they keep their fingers just in front of the point where the needle enters the animal, and we are not supposed to see that, apparently. When we look at the chapter on surgery of the rat in the same book, written by Ingle and Griffiths, we see some remarkable things, especially when it comes to asepsis. Here they say that rats are less susceptible to post-operative infection than are many other animals. As a matter of fact, if all aseptic precautions are disregarded, but the operation is carefully performed and the animal kept in a dry cage, many of the animals will remain free from infections after most procedures. So this is very vaguely formulated. If you read a little bit further, you see that they keep animals dry by changing newspaper frequently. And the last sentence is absolutely the hammer. It says, if the animal is more valuable, the hands are rinsed in alcohol. So apparently at that point in time, there were valuable and less valuable animals. Okay, I'll leave that up to you. This was a book that was studied by my teachers. So fortunately, I was very lucky to have a teacher that was using aseptic technique at the implantation of the jugular vein catheter. His name was Anton Steffens. Unfortunately, he died a couple of years ago. Another book that was the Manual of Laboratory Work in Mammalian Physiology, that was published in 1948. And yeah, look at these pictures here. This is the cannulation of the jugular vein, and you see that the fur is still on this animal. The wounds are cut in a crazy way. It looks very, very dirty, and people were working barehanded. So this is absolutely not the way you should do it. That changed. And it changed when we started to bother about the 3 R's, about replacement of animals in medical experiments, about the reduction of the numbers of animals, and about refinement of the technique. And this is all thanks to the book that was written by Bill Russell and Rex Butch in 1959, The Principles of Humane Experimental Technique. After I did my PhD, I worked for a company, Dufar, that later became Solvay, and we had this book on the shelf. And our head of pharmacology, Volker Klaassen, he read the book, and he underlined several pages that were really important. So again, I was very happy that I was in an environment where they cared for animals. In 1983. At the veterinary faculty at Utrecht University, Professor Bert van Zutphen established the Department of Laboratory Animal Science, and he started with his team to educate the scientists, and those were Article 9 people, and also the animal welfare officers, Article 14 of our law, and that was a big step forward. The of the pictures you see the MD-PVC rat. That's the one of the products of Microsurgical Developments, a foundation that I have the pleasure to chair for already more than 35 years. And here you see a hooded rat looking at a plastic colleague, where you can train more than 25 experimental techniques. Below you see our Practi rings that we use to train eye-to-hand coordination under the microscope. It's a very simple thing. You do not have to do this on animals, of course. So this is pure replacement of animals. In a couple of slides, we will see that anatomy and anatomical knowledge is very important. And some years ago, already 20 years ago, we decided to make a 3-dimensional model of the rat. And here you see it in Bologna, on one of the congresses on the replacements of animals in medical experiments. It's a beautiful model, and you can study some 400 structures there. Going to the principles of not harming, because this is, of course, important, that you do not harm your animal. Before we had anesthetics, speed was, of course, the most important factors. Patients should be as short as possible in agony, and therefore the procedure had to be carried out extremely quick. Robert Liston, the guy famous for his long, razor-sharp Liston knife, and you can see him holding it in his hand, was the absolute champion here. He could do a lower leg amputation in 28 seconds. So that was extremely quick. He's also, sadly, the holder of 300% casualties in one surgery because his patient died after the surgery. And he was so quick with his knife that he cut off 3 fingers of his assistant, who died from sepsis. And a person in the audience who witnessed this whole scene died from a heart attack. So there were 3 dead people in one surgery. The birth of modern surgery was a fact because time was no longer the most important factor, and there was invasion of the body. People hardly dared to invade the body, but that was possible by then. And one of those maverick surgeons was William Stewart Halstead. And here you see Halstead 1 year before he died, and Halstead was the guy who took the Hippocratic approach one step further. He did not. He took harming the patient one step further to not harming the tissue of the patient, and that was a big step forward. So let's have a look at that. Here are the basic principles of Halstead's contribution to not harming the tissue. Again, if you want to know more about Halstead, this is a very nice book from Gerald Imber. It's called Genius on the Edge, and it describes the bizarre double life of William Stewart Halstead. Why a bizarre double life? Simply because Halstead read a paper from an ophthalmology congress in Heidelberg, and their Dr. Koller, was presenting a paper about cocaine and the numbing effect of cocaine. So Halstead ordered several kilos and started to experiment with it. Don't do that today, by the way. So he used cocaine on himself, on colleagues, on students, and you can imagine that half Johns Hopkins Medical Center was hooked on cocaine within a couple of months. But beside that, he kept his addiction hidden for most people. He was hospitalized in 1890, and the standard treatment for cocaine addiction at that point in time was morphine. So he came out of the hospital having 2 addictions. His tenets, however, are really very, very important. And this is what I call today good surgical practice. Gentle tissue handling, know the anatomy. Already mentioned that with our anatomical model. Tissue exposure, very important. Today we had people doing surgery and still exposure of the tissue is not perfect, and you have to show it to them. Look, place a hook here, place a hook there, and then you have clear view on the area of interest. So really very important. Hemostasis, of course, important, especially when you work with animals as small as a mouse with only 2 milliliters of circulating blood. Preservation of blood supply is important. Tension-free wound closure, very important. And asepsis. He was one of the followers of Joseph Lister, and we will come back to that in a couple of slides. So let's zoom in on a couple of Halstead's tenets. Gentle tissue handling. Remember that every time you pick up tissue with your instruments, you kill cells. Keep this in the back of your mind every time when you do surgery, because you should try to kill as few cells as possible. Be goal-oriented in your approach. And that means that sometimes sharp dissection can help you, but if sharp dissection is too dangerous, you must do blunt dissection. So this is one of the rules of stump: sharp when can, blunt when must. A very nice paper that I will mention more often in this webinar is the paper The Thin Blue Line, written by Dale Cooper and colleagues and published in 2000. And in that paper, Cooper mentioned that the contribution of surgical technique to the prevention of post-procedural infections is probably equal to that of aseptic technique. And that's quite a saying, but I agree with him. The exposure of the tissue, very important. Make sure your view is unobstructed. So don't push a liver lobe away when you have to do something in the portal area or in the bile duct, but make sure that this liver is nicely pushed away with a sterile gauze soaked in sterile warm saline. Have proper illumination, have good physical access, really important things. So Halstead was a guy who said, don't make your wound too small. And I also tell this to people when they start to develop a certain skill and a certain technique. Make your wound sufficient in size. It will automatically become smaller when you have more experience in the technique. But when you do keyhole surgery from the beginning, you miss all the landmarks, and then surgery becomes very difficult. By the way, don't worry too much about healing of the wound. It is not primarily affected by the size. Wounds heal from the left to the right and not in the lengths. And what is more important is proper approximation of wound edges with low suture tension so that blood can be supplied to the healing spot. And if you overtie your sutures, you decrease the blood flow and you will have very weak scars. Hemostasis. Again, very important. In small laboratory animals, and a lot of you in the audience will work with mice, this can have serious consequences. If you lose more than 10% of the circulating volume, your animal gets into trouble. That means in a mouse, a small mouse, not more than 200 microliters, and that's not too much, of course. The first thing you should do, or in fact not do, according to Hitchhiker's Guide to the Galaxy, is panic. Because if you panic, your animal is most of the time lost. The immediate thing you do is put your gloved finger on the bleeding spot and apply light pressure. During our courses, we ask the student to put their hands in the air, and we will let them sit there with their finger on the bleeding spot and the other hand in the air for 2 minutes, and then we pay attention to them and we ask them, what's happening? And then they say, yeah, they're bleeding. And then we ask them to remove their finger, and much to their own surprise, the bleeding has already stopped. So this is psychology, and it helps people to be not lose their ease when they have a bleeding. It's not the end of the surgery. You can still save your animal. Other ways of stopping bleeding can be coagulation. I'm a big fan of the bipolar coagulator. That works very nice and very local. A bit less local is the Cauter. That's a heated spiral that is approximately 1200 degrees centigrade, and in front of this heated piece of metal you see the tissue shrink, and that of course spreads some heat in the tissue and will definitely be felt when the animal recovers. Ligation is very simple. Put a ligature around the blood vessel and tie it. But we also have very nice hemostatic sponges at the moment for the chemical treatment with collagen fibers, adenosine diphosphate. The very new ones, Tachosil and Fibrillar, they also contain fibrin and thrombin, and they are excellent hemostatic sponges. They are resorbable, so you can leave them in the animal and they will be resorbed. Last but not least, asepsis. I told you he was a follower of Joseph Lister, and Hallstatt used meticulously sterile technique. This is one. The second thing that you should do is, and that's as important as the first one, is that you should make life miserable for bacteria, in fact. So create conditions that are not favorable for bacterial growth. And that means remove foreign tissue, dead tissue, remove foreign materials, because in the presence of a foreign material, you can have a up to 7 times higher chance on an infection. Remove blood together with serum, as that is simple food for bacteria. So learn from the past when it comes to asepsis. And here you see a couple of front runners in the quest for asepsis. It started with Ignaz Semmelweis. Semmelweis reintroduced the hand washing. Hippocrates already told his students to wash their hands between students, but that was forgotten in time. And Semmelweis tried to fight the childbed fever. A high percentage of healthy women giving birth died a couple of days after giving birth, and that was due to paemia, to blood poisoning. And Semmelweis followed the students that did the deliveries and found out that they very often came from the morgue and without washing their hands did the deliveries. And that caused, of course, blood poisoning. He called it cadaver particles because there was no name for these things, for these germs at that point in time. Pasteur played an important role of doing research about fermentation and putrefaction of dairy products. And then the father of aseptic surgery, Joseph Lister, his father was a microscopist and he was raised with a microscope, and he used this very often. And yeah, he was a bit calmer character compared to Ignaz Semmelweis. And he traveled around the planet telling people that they had to change the way they did the surgeries. And some people said this guy is crazy. He has a cockroach in his head. This was one of the comments of the surgeons. And that's understandable, because when people have done a certain job for 30, 40 years, and then somebody comes and tells them that they did it all wrong for 30, 40 years, they will not be happy. Also, William Stewart Hallstatt contributed to asepsis in a special way by introducing the surgical gloves. This was done because his chief nurse, Caroline Hampton, had a dermatitis due to the antiseptic, which was mercury chloride that they used. They dipped their hands in it, and she wanted to quit her job. But Hallstatt told her, I'm going to solve this problem, as you are an unusually efficient woman, he told her. Anyway, they fell in love after that. So, and she became Mrs. Hallstatt. And they introduced the gloves, and they found that the gloves were not only good to protect Caroline, but also to prevent post-surgical infections. So we know all this, but the question is, do we also practice asepsis? And have a look at this slide. This is a cut tomato that looks very juicy and nice, but there are things in there that do not belong in the tomato. So my question is, why do we bother so much about the health status of our animals whilst taking no precautions during surgery to prevent pathogens from entering the wound area? And then we automatically come to a very nice book written by Lindsay Fitzharris about Joseph Lister's quest to transform the grisly world of Victorian medicine. And the book has the catchy title, The Butchering Art. It's not for the faint-hearted, by the way, but it's beautifully described. What has thought to be impossible has now become achievable. Surgeons in the early 1800s were talking about pus layers on a wound, and that was good. That was a good sign that the wound was healing. It was called laudable pus. When you had to pick a surgeon, you picked a surgeon with the dirtiest clothes, simply because that was the one with most experience, not knowing probably that he was also probably the person with the most pathogens on his clothing. Infections coming out of the air, that was, of course, based on Pasteur's findings, but that was not completely true. You could also have them on your hands and transfer them to the patient. It changed further. Important contributions of Koch with his postulates in 1882. And when you read the book, you see that there were many parallels between clinical surgery and experimental animal surgery. So take care. And here you see a beautiful cartoon, and you immediately see the dullness in the eyes of the suicidal setter and the twinkle in the eyes of the happy setter. If not, you should have a closer look. These animals do not look ill, but a lot of animals are ill and are unsuitable for research. And this is beautifully described in a paper published in 1992 in Laboratory Animal Science by Bradfield from the group of Stephan. It's about behavioral and physiological effects of inapparent wound infections. They deliberately infected animals, and 2 days after they infected them, they asked somebody, have a look at these animals and tell us what's an infected animal and what's not. And the person who had to do that said, they all look fine. You did a great job. But 50% of those animals had an infection. So when people tell you, oh no, my animals are looking fine, that is not true, probably. It is not. You cannot see that on the outside of the animal. You have to do some SAA test to see if there are bacteria in your animal or not. Reduction of trash, that is really important. Your surgical technique is important. And for your surgical technique, you need instruments, surgical instruments. So here you see the forceps. We start opening the skin with rat tooth forceps. Then we follow up on the weaker tissue, on the soft tissue with anatomical forceps. And as soon as we start to increase the magnification at the microscope, we go to the microsurgical forceps, or Jeweller's forceps. Very important is how to hold your instruments to reduce unwanted movements. And that's the pencil grip, and you see it nicely demonstrated here. And on the right of the slide, you see that artists also use this trick to support their hands to be able to make very nice paintings. And that is something that a lot of people forget. If your fingers are or your hands are in the air, you move 2.67 times more than when your hands are on the table. The sutures and the catheters that we used in the past were, first of all, the sutures were traumatic. And that means that we used eyed sutures, so eyed needles. So through the tissue, you had 1 time the thickness of the needle and 2 times the thickness of the thread. We have completely left those needles, and we work exclusively with swedged on atraumatic material. We also used to make our own catheters, and I made the catheters in the past of silicone, and you know that silicone is really a dust magnet. So these catheters were absolutely not clean. We tried to clean them as good as possible, and we sterilized them in the autoclave, but still they were probably much dirtier than the catheters we buy now that are produced in clean room technology and are ethylene oxide sterilized. So that's a big step forward. We use resorbable and unresorbable synthetic sutures that have a very low reaction rate in the tissue. Another major breakthrough from the last decades is the introduction of the pin port and the vascular access buttons. Here you see a very nice overview of pin ports, vascular access buttons for rats with 2 channels, 3 channels. There are even buttons with 4 channels, and you can do all kinds of connections with them. So you connect, for example, bile flow with a duodenum catheter, and then the animal has an intact enterohepatic circulation. So very nice. Also in mice, and you see these red caps there. You can put them over these pin ports, also in the rats, and then you can group house your animals. And this is something that we wanted for a very long time, because we know that animals recover better from surgery when they are in a social group. The minimalization of trash and trauma and time, the 3 T's. We still have a way to go. Good instruments are important. Good instrument handling is important. Maximize support and only have tension between your thumb and your index finger. And then you will be able to do miraculous, accurate manipulations under the microscope. And everyone can do that. The proper suture technique is important, and we use braided, woven, twisted sutures, but be careful with them because they cut through tissue. Monofilaments are fishing line. They have a low tissue drag. They do not cut, but you must tie different knots with them. Very often a 2 is 1 is 1, or a 2 is 2 is 1 is 1 knot to let the knot be very secure. One thing, and this is all Hallstatt, approximate, don't strangulate. Never, ever overtie your sutures. Low suture tension gives you stronger scars. This is a sentence you can find in a lot of papers about suture material. Asepsis can help to keep the bacterial contamination below an infection threshold. But remember that the chance on postoperative procedural infections is 7 times higher on an implant. And we had this discussion today with one of our students. Time and trauma also contribute to post-procedural infections. If there is prolonged exposure of tissue to adverse conditions, hypoxia, impaired blood supply, if there is a residual blood, debris, or devitalized tissue that is food for bacteria, all these things can increase the post-procedural infections. Also, hypothermia can increase the infection rate. So, nice work of the group of Claire Hankinson, stop the drop. And here you see the effect of core temperature drop when you apply some substances on the skin for disinfection. So aseptic technique is very important. And here I have some quotes from the Thin Blue Line paper of Dale Cooper and colleagues. Aseptic technique during surgical procedures is essential to prevent pain and distress associated with post-procedural infections. Modification of surgical technique, so the reduction of trash, may provide more protection from infection than a sterile drape does. And the contribution of surgical technique to the prevention of post-procedural infections is probably equal to that of aseptic technique. Strong sayings, but I think they are very true. So how can we improve things 80% with changing 20% of our habits? The Vilfredo-Pareto rule. Now, first of all, strict asepsis is the best. That goes without saying. If that is a problem, minimize the initial contamination. Try not to reach such a level that an infection can occur. Time, trauma, and trash, very important. So your surgical technique, again, is paramount. And please work on that. Very important. Incision foils, you can use the very expensive one. We have very good success with the press and seal. Is what tested, and it was found not to be completely sterile, but it is much better than not covering the animal. And if you send them for gamma radiation, you can have them sterilized. Much cheaper solution compared to the incision foils. The most important message here to improve is do some logistical changes. Plan your surgeries properly. Try to work with an assistant. Have one assistant for several surgeons. Try to form teams, and then you will see that your surgeries will be much more quick and much better results in the end. Also, the perioperative care is important. In the Netherlands, we published a code of practice in 2023, and of course, we spend a lot of attention to body temperature and to fluid balance. Now, the body temperature under anesthesia is dropping. The animals become poikilothermic. The environmental temperature plays an important role. Animals are dropping in temperature, so they become hypothermic, and then you have to conserve heat or supply some extra heat to warm them up again. But it's better not to let them cool down and keep them in the physiological range. Don't cook them, because hypothermia is as killing as hypothermia. Fluid balance also important. Fluid loss can be via the respiratory tract if you give them dry inhalation gas. The operation area, urine, they can pee a lot. But also blood loss is a form of fluid loss. If it's only water loss, you can compensate with warm saline. And if it's blood loss, you should add extra things, preferably blood, but you must definitely supply some proteins there. When you do surgery, it's important to keep an eye on your animal. And the equipment, the physio suite, for example, or the right temp from they can help you to monitor your animal while you concentrate on your surgery, and they can give you alarms when certain parameters are out of line. So with the temperature, make sure you stop the drop and have a look at this paper that is mentioned here. Animals can die untimely when they are too cold, because anesthetics gain in potency when the temperature drops, and then you are in fact overdosing your animal. They cause a prolonged recovery time, and you have a higher chance on post-procedural infections. The pulse oximeter is a very valuable instrument. It gives you constant information on the animal's heart rate, its respiratory rate, and its partial oxygen pressure. Be aware of the fact that when you have mice under injectable anesthesia, that you have to give them oxygen. You see here a very nice oxygen concentrator that delivers 1 liter of oxygen of 93%, and you can give your animal oxygen during the anesthesia. This paper with James Marks is very interesting to read. It's about mouse anesthesia and the art and science. Very interesting paper, and this oxygen suppletion is really crucial. Then in the post-operative phase, of course, we must treat pain when there is pain. Always look at the necessity. And if you do very good surgery with very skilled tissue handling and with an adequate painkiller at the end of the surgery, for example, an NSAID, carprofen or meloxicam, your animal will do fine. This is a scheme that I took from a book called Pain Management in Animals, edited by Paul Flagnall and Avril Waterman-Pearson. And it's a very nice schedule to study and to see where you can add specific things, local anesthetics, or when do you start with NSAID treatments, or when do you start with opioids. Be very careful with opioids, because they can make your animals nauseous, and a nauseous mouse or rat will start to eat non-nutritive substances because they cannot vomit. And in the laboratory situation, they will start to eat bedding. NSAIDs are very nice, and we use a lot of carprofen and meloxicam to kill the pain in our animals. Last but not least, a few words about telemetry. Here you see the first telemetry measuring at a distance. This was 1869, the shortening of the pectoral muscle of a pigeon, and you see that the signal was written on the chemograph. Today, it is much more refined because we know that handling and restraint has all kinds of negative influences on blood pressure, body temperature, oxygen consumption, etc., etc. And we also know that anesthesia has its effect on the animal and on the result. So we prefer to have no restraint, no handling, and no anesthetic when we measure. And telemetry offers that chance. That it's a form of refinement can be illustrated with this nice picture here. This was the first blood pressure measurement in a horse, and this was Stephen Hales in 1733, where the horse was tied to the ground, a brass tube was inserted into its carotid artery, and they just marked the level to where the blood was rising, and then the horse was killed. So enough space for refinement, I would say. Telemetry is a really important tool today, and especially in safety pharmacology and in pharmacology, we use a lot of radio telemetry in species such as guinea pigs, rats, mice. Freely moving animals can be used. You can measure their electrocardiogram, electromyograms, electrooculograms, blood pressure, left ventricular pressure, right ventricular pressure, bladder pressure, corpus cavernosum pressure, brain pressure. All kinds of pressure can be measured, and that's really very nice in freely moving awake animals. So there are people who say telemetry is the truth. I'm not sure if you can say that. I think it's very close to the truth. In the ECG, you can see QT prolongation, which is a longer QT interval that can lead to torsade de pointe. And the lead position is here, lead 2, as you can see in the little figure there at the bottom right. It's Eindhoven's 2 position. If you want to know more about electrode position in radiotelemetry, have a look at the paper of Andrea Scoifo from 1996 and Marcello Tontadonati from 2011. Blood pressure can be measured. Most of the time in rats, it's done in the infrarenal abdominal aorta or in the femoral artery. And in the mouse, it's done in the left carotid artery, according to the Butts and Davison technique from 2001. Then some recent developments, and that is we are really going in the right direction. Battery life was often a limiting factor in radiotelemetry, and refurbishment of the complete transmitter was in fact a standard procedure. Caja now was the first to develop a reliable rechargeable system with a Millar solid-state pressure sensor, a very accurate sensor, combined with a power lab for high-quality data acquisition, and with the computer program LabChart that allows you to analyze your data. And believe me, when you sample half a day, you gather so many data that you will probably suffer from data stress. And these programs can help you solve those problems and interpret your data. So I would like to finish with some take-home messages. And here they are. Do not train yourself. Select your teachers carefully. Learn from the past. Asepsis is crucial, especially in implantation surgeries. Good surgical practice is paramount, and these practices may maintain bacterial contamination below the infection thresholds. Reduction of trash is the focus of aseptic technique. Our surgical technique will help to prevent post-procedural infections. Use the proper instruments for the job. Do not work with a rat tooth forceps on muscles or on other weak tissues. That's not a good idea. Do logistic changes, this planning substance, and work with an assistant. If you do not have an assistant, the obvious answer is hire one. Next to trash, time, and trauma, they contribute to post-procedural infections, and you must pay attention to that. Shorter operation times, less trauma done to the tissue, those are all factors that are really important. The next generation of radiotelemeters from Caja solves the battery problem. They are rechargeable, and you will never end up with an empty battery. Train yourself, go to a good training, practice, 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 and train, train, and retrain. I thank you for your attention.
Thank you so much, René. Such a fantastic presentation. Ready to jump into the Q&A if you are.
Okay, yes, I am.
Okay, so the first question here is, I was taught that blunt dissection provides quicker healing than a cut with scissors. Is that false?
That is false. Yeah. Yeah. Vets will always tell you to use a scalpel to make a nice, clean wound. Now, that is true for a lot of animals, but in small animals such as rats and mice, you should in fact not use scalpels. We use scissors to do that, and that's also a form of sharp dissection. The scissors have the advantage that they compress the blood vessels, that they crush them a little bit. These vessels go in spasm, and there is hardly any bleeding. A scalpel is so sharp that when you cut through the skin, the little vessels in the skin will stay open, lose some blood, and then come to a contraction. So, especially in a mouse, never ever use a scalpel, but use scissors. And then I know that you have to use the scissors in a special way. You must grasp the tissue and cut with your scissors parallel to your forceps. And if you do that in the correct direction, you have a very nice sagittal incision that you can enlarge when you want by putting pressure or tension on the wound.
Okay.
Short answer.
Yes, absolutely. We've got so many questions here. I know we are running a bit short on time. I did want to, before we continue with the questions, just for the audience, if you do have to leave before the end of the webinar, I would absolutely love it if you would take part in our survey about your experience today. So that will pop up for you if you have to leave early. Okay, back to the Q&A. Someone has asked about the effect of suture size. What size do you recommend for skin and connective tissues? I'm assuming in mice.
Okay, I will talk about rats and mice. I will talk about rats and mice. Yeah, the majority of people use sutures that are far too thick. As a rule of thumb, in the rat at the outside, the thickest diameter that you use is a 4/0. We prefer a 5/0 even. Internal in the animal, the thickest diameter should be 6/0, but we prefer 7/0 to use in a rat. In a mouse, the biggest diameter on the outside is 5/0, but we prefer 6/0. And internal in the mouse, it is 7/0, and we prefer 8/0.
Okay, hopefully that answered his question. There is there's so many questions here.
Don't panic.
Somebody has asked, clearly strict aseptic technique is key, but I wondered what your thoughts are regarding prophylactic and post-operative antibiotics for implantation surgeries.
Yeah. First of all, post-operative antibiotics is not the way forward. Burke published a paper in 1961 in Surgery saying that you have to give them prophylactically. And indeed, I read every now and then a paper saying after the operation, all animals receive some kind of antibiotic. That's against the art. If you use antibiotics, use them prophylactically. So give them 15, 20 minutes before surgery. Then you build an umbrella over your animal. And when a bacteria is coming into your operation field, it will be killed immediately. Don't wait until after the surgery, because then you have the chance that you have to fight millions of bacteria instead of only a few. So it is prophylaxis. You only give them once, and you do not treat them for several consecutive days.
That makes perfect sense. Amazing. Oh my gosh. Okay. We are a minute over time. I'm going to make this the last question. But I will be sending a copy of all of these questions to René and to the ADI team. So please keep sending them in, and they will be addressed in a few days. Yep. Okay. So a few questions here about intradermal sutures.
Yes.
Is this a good option for rats?
Yeah, Very good option. You can do that with a 4 or a 5-0 resorbable suture. We use Vicryl, polygalactin 910, to do that. And it's a beautiful technique, but you must do it in the proper way. If you do it wrong, then you get holes in the suture line. Perhaps I can explain this better by making a picture when I answer these questions. But it's well worse. You end your technique with a Aberdeen knot, which is a bulky knot that you pull underneath the skin, and then there is no thread visible. We even do this in the mouse with a 7-0 resorbable suture. And it's a beautiful technique. It is somewhat time consuming, I must admit that. But yeah, there are a lot of students of us that still do this technique and make it the standard. Yeah.
Okay, fantastic. Like I said, I'm going to end here, but there will be a Q&A report after this, so we will address your questions directly. René, I just wanted to thank you so much for your time and your expertise today. Amazing presentation, your insights in the Q&A, so fantastic, and I can't wait to have you back for another webinar. In closing, we hope that you enjoyed this Inside Scientific webinar produced in partnership with the American Physiological Society and sponsored by AD Instruments, and I hope that you enjoy the rest of your day. Thank you.